It's a great pleasure and honor to be with you guys. Unfortunately, not in person, hopefully next time. And I'm going to talk about, I know you have a few talks now about tumors. I know Paul is going to talk about intramedullary tumors next. And so I want to talk to you a little bit about extramedullary, intra and extraspinal tumors and how you can leverage MIS, minimally invasive surgery. And we use a lot of navigation, and we've recently started using augmented reality, especially for tumors. And I want to show you a few cases that we did and see what you think. And, hopefully you'll like what I'll talk about, of course. Now, minimally invasive spinal surgery is obviously a big interest of mine. And we came out with a, like an expert-based definition. Essentially you're trying to achieve the same outcome or hopefully better outcomes by avoiding collateral damage to the soft tissues by using technology techniques to protect soft tissues and minimize bone resection and so forth. And for tumors, that implies that instead of making a big open incision, exposing multiple levels for, and most of these tumors that I'll talk about are in the lumbar spine, instead of making a big incision, resecting the muscle, doing a multi-level laminectomy, we try to really target these intraspinal and sometimes extraspinal tumors through tubular retractor. Essentially, we're doing the same that we would do now for MIS laminectomies, for discectomies, for lumbar stenosis, using slightly larger size of tubular retractors, but using the same surgical technique that you would use for tubular decompression. The challenge then is obviously the microsurgical part once you open the dura, and then how you close the dura. But I think we've pretty much tackled that for the majority of these lesions. Now, the advantages, and this is a little provocative here, obviously on the right side, but that's not what you would do for an intraspinal tumor necessarily. But the idea is obviously you minimize the size of the incision, less blood loss. CSF leaks are not a big issue because of the soft tissue coverage that you get with the tubes. And these patients are in and out. Usually we keep them in the hospital maybe 24 hours, bed rest, get them up. Frequently they go home the next day. There's a little bit of literature on intraspinal and extraspinal tumors using minimally invasive, primarily tubular retractor. There was a focus issue, neurosurgical focus a few years ago. And obviously, Rick Fessler, a lot of the Asian authors and others talked about this, but there's no real large series out there. Nobody has really described a reproducible kind of how do I do it technique. And that's what we're trying to really address in this publication that I'll talk about. But most of these studies show that in terms of complication rates, operative times, MIS approaches can be very beneficial for selected tumors. They have to be selected, obviously, for this procedure. Now, in addition to tubular surgery and bayoneted instruments and the microscope, what I've always been interested in is just like Rod, you in Seattle and many of the others here, is really navigation. How can you incorporate navigation, and what does navigation really bring to the table long-term in terms of making your surgery more targeted, more efficient, safer, and hopefully less invasive? And I'm a big believer that if you use navigation properly, you can really add to all those factors, and it can make surgery more focused, safer, and so forth. So we introduced a concept called total navigation, where we don't use any fluoroscopy. We do everything with navigation, meaning that we get an intraoperative CT scan when we position the patient, and use navigation from the very beginning for placement of the incision, tubular retractor, for the orientation inside the spine, over the top decompression, and so forth. And obviously, if that patient needs instrumentation, that also for the placement of screws and cages and so forth. So we call that total navigation. So nobody wears lead. You get a spin at the very beginning, at the very end to make sure, but in between there's no technician needed. You really you can do this operation without having to interrupt for fluoroscopy and so forth. And in my opinion, that really streamlines the workflow. So this is a case, this is an extraspinal tumor that we did when navigation came in very handy in the tubular approach. There's a tumor, there's a patient who had, a young patient who had radicular pain, had this foraminal enhancing mass. If I did this open, would be, I would think about maybe having to resect the facet joint, maybe having to do a fusion. With a tubular approach, we came in like extraforaminal, resected the lateral aspect of the facet, removed the tumor, and this patient was in and out basically within a day. This turned out to be a schwannoma. So this is the patient positioned on the operating room table. We get this intraoperative CT scan. Now with these new scanners, you can minimize the amount of radiation. You can get 100% scan, you get 50 or 30% scan. So in these cases where it's just localization of pathology, we frequently get a low dose intraoperative CT scan of the very selected anatomy. And we measured that and compared it to diagnostic CT scanners, and a 50% scan is indeed about 50% of the radiation that a diagnostic CT scan would expose the patient to. And then we start navigating. This is the fellow a few years ago with the reference array, looking at the screen here, localizing the placement of the incision for the tube. And then we merge the intraoperative CT scan with the preoperative MRI scan. So you can see here that schwannoma in the foramen expanded the neuroforamen here, and we merge the MRI of the CT scan, so we make the perfect trajectory for the tubular retractor. The reference array is here on the iliac crest. We came in from the left side, about 5 or 6 centimeters off midline. Place the tubular retractor, brought in the microscope. Obviously, you have to dilate the muscle. You find the capsule of the tumor, and then we start debulking the tumor, resecting the tumor, obviously with intraoperative monitoring. You always want to protect the nerve, of course. And this is the postoperative MRI scan. So we resected the lateral aspect of the facet joint, but this patient didn't need a fusion and did really well. Now, I want to show you a series of patients that we did. Now, these are mainly intraspinal, intradural, extramedullary tumor. So this was just submitted for publication, but it's a series of 20 patients, mean follow-up 21 months. The tumor size was, small to medium, 15 millimeters, I think up to 2.5 centimeters, maybe 3 centimeters was the biggest tumor that we treated with this approach. And these patients were all treated with a tubular approach. We use a 26 millimeter tubular retractor for this. 2 patients required a fusion because of the resection of the facet joint that was necessary. And these were the pathologies that we saw. And we tried to write this up in a step-by-step fashion to give surgeons like a ability to hopefully replicate this technique. So we use navigation for every step. We also use augmented reality now. More recently, I'll talk about that a little bit. But basically, we position the patient. As I mentioned, we get a low-dose intraoperative CT scan. We dilate with the tubular retractor. We do a unilateral laminotomy for bilateral decompression. So we angle the tube, go over the top, undercut the spinous process, do nice bilateral generous decompression of the thecal sac, then open the dura, use tack-up sutures, do intradural. It's exactly what we would do with open surgery. And at the end, we have a special set of dual closure devices that we use to get a watertight closure. And then those patients go to the floor for 24 hours. We mobilize them after 24 hours, and then they go home either that next day or the following day. And this is our recent fellow, Lynn McGrath, doing one of those cases. So this is the localization. This, again, lumbar schwannoma, the reference array on the iliac crest. And we had an artist kind of draw this up. You can see that tumor projected under the skin. And we planned the skin incision. In this case, we used augmented reality. So we outlined the tumor on the preoperative MRI scan, merged it with the intraoperative CT scan, and then under the microscope, you can basically, you look under the microscope and you can see the outline of the tumor from the very beginning, even before you make the skin incision. And that kind of helps you orient the exact trajectory of your tubular retractor. So this is now dissecting the muscle. You can always kind of see the shadow of this tumor. And it really helps you under the tube, to angle the tube medial, up, down, depending on exactly where the tumor is. So that's what we're doing. We're doing a unilateral approach here with the tube. I usually use a 26 millimeter tube now, undercut the spinous process, and then come down to the bone, and then angle the tube medially so we can go over the top. This is the, 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 and And then we do the over the top by angling the table away and tilting the tube towards us so we can get that trajectory under the spinous process, do the contralateral decompression, and then here is, again, the intraoperative CT scan merged with the MRI scan. Here the fellow outlined the tumor in blue. You can see that it was a pretty big tumor in this case. And then again, we exposed the dura. So now we got a really nice exposure. You can see that the tumor is right in the center of the tube, and we make an incision in the middle of this lesion, and with a 11 blade knife, use tack-up sutures, and we thread the tack-up sutures. We have a technique where we thread the tack-up sutures through, under the tube, so we really get a wide opening there, and then we start dissecting the tumor with Roten. You can get bayoneted Roten micro instruments to work through the tube, and this turned actually out to be a paraganglioma, I think. It was a vascular lesion, but we got it out very nicely, and then we got a watertight closure with this Spinal and Dural repair set. Use fibrin glue or Duracell, and then as I mentioned, keep those patients one night in the hospital usually. This is a video. I'm just going to show you if this works. I don't know, but I think the memory is a little bit slow here. So now we're stuck. Anyway, any questions? I have maybe 2 more slides after this, so. I'm sorry, this PowerPoint is stuck now here, so.
No, it's okay, Roger, take your time. This is great. So let me ask you something, because I wish I could show you this case I did the other day, Roger. I was thinking about you. I know obviously you do open surgery as well, right?
Sure, yeah.
I think one of the things I've appreciated with doing MIS surgery is the soft tissue coverage you lose when you open the patient up, especially for tumor cases.
Yeah.
So I don't know. I know you guys probably. I mean, on some of these big open cases. I just did a lady with this massive neurofibroma that was filling up her entire sacrum, and it went all the way up to L1. We had to do it open, but healing and infection rates and all those things become more of an issue. So yeah, I'll let you back to your talk. Sorry, Roger.
No, I'm pretty much done. Unfortunately, the video is the size. I mean, basically, the video just shows how we use the augmented reality. It's a similar case that I showed on the slides, but it's nice to see it on the video, to see how the augmented reality kind of plays into this. So I can just, I don't know if this is going to work. Yeah. So basically, that's the view under the microscope. So you can see the projection of the tumor from the very beginning, and then we bring in the knife and we open up the dura. And a lot of these tumors are really connected only to 1 or 2 nerve roots. So sometimes they just deliver themselves. And for these cases, I mean, it's great to be able to do it MIS, like the case that you mentioned, that big sarcoma. There's no good MIS way to really treat that, but you gotta, but those are rare cases, and these schwannomas are relatively common. So if you got to look at the big picture. If you can do 70% of all spinal tumors with MIS, that's a huge number. You will still have to use open surgery for certain tumors, of course. But even for open surgery, then maybe you'll use navigation, maybe you'll use other, part of it you can do with less invasive technology. So you can leverage some of the, certainly the navigation and the augmented reality. You can use that for open surgery as well. So that's why, I think it's worthwhile looking into this. Look, this tumor comes right out, right? And you just got to find the nerve that's going in, then the other nerve that's coming out. We stimulate those nerves, make sure that they're mute, and then we bipolar and cut the nerves and resect the lesion. And then
What do you do, Roger? Do you use like, you obviously close the dura like you would normally, like with the 6-0-proline?
Yeah. Yeah, we close the dura with a, we have a, so that's the dural closure now. I use a Gore-Tex. You know, the key is really the needle. You got to find a small needle. And then this is the Scanlon dural repair set. There's I think Rick Fessler or Kevin Foley told me about this. And these instruments work really, really well. They're bayoneted endoscopic dural repair instruments. You can purchase them, Scanlon. There may be other, maybe I'm not supposed to say that, I apologize. But people always ask because it's hard to find the instruments really that help you do this dural closure. And I use a Gore-Tex, this particular Gore-Tex with a 6-0 needle. And then you do a Valsalva. You see here, there's still a little bit of an opening. Mm-hmm. So obviously you want to get a watertight closure. So we put a figure of 8 here and then cover everything with, we use a ball tip as a knot pusher and then cover it with Duracell or with fibrin glue, and then that's it. And then we take the tube out. We use flow seal for hemostasis. Again, I'm not supposed to say that probably.
And what do you do? Tissue or
fibrin glue, and then when I take the tube out, most important thing is really to get hemostasis, because if you don't do that, these patients have post-operative a lot of pain and muscle spasms, sometimes days later. So I always bipolar the muscle when I take the tube out, and then get a nice closure, obviously. Sometimes nylon, or sometimes sub-Q. If I'm really happy with the dural closure, I just do the sub-Q at the end. If I'm not 100% happy, then I do nylon. All right.
That's terrific. Thank you so much, Roger.
Yeah.
Always great to see you, and obviously would be better to see you in person, but it's still good to see you via Zoom.
Thank you.
And
same here.
Really great talk, and really cool stuff you're doing. So great to have you.